get it back over. I don't need that.
You guys ever go to those, like we went a lot when we were doing our renovation because it's so close. The perimeter one was so close to where we live. So we went a lot.
And we are recording, correct?
And they were like in the process of, I think, trialing some things on their
It's being recorded and we're good. Okay,
and then we
awesome.
stopped going once the kids were done.
Okay, hello everyone. We're going to go ahead and get started. Welcome to all of our live remote sites watching from all over the Southeast. We're going to go ahead and start. We always start our meetings by stating our mission. The mission of the Southeast chapter is to emulate SCCM's mission, which is to secure the highest quality of care for critically ill and injured patients in the Southeast region by providing educational and research opportunities as well as promoting multi-professional collaboration. So thank you again for everyone for coming. We'd like to give a thank you as well to our sponsors, La Jolla, Astute, and Allergan. We have just a few announcements to get us started, and actually by a few, I mean quite a few. We've got a lot going on with the chapter these days, so bear with us real quick. First, I want to give a huge thank you to our outgoing president and our newest immediate past president, Marina Rabinovich. Her leadership over the last couple of years has been fantastic, and we've done some great things. I also want to say welcome to our newest executive board members, our new president, Megan Van Berkel Patel, PharmD at Erlanger Hospital in Chattanooga, as well as welcome to our newest treasurer, Rita Gayed, and she's a PharmD at Grady Hospital Burn Center, and our newly elected treasurer. And Marina Zorni is our newly elected secretary for the chapter, and she practices as a PharmD at Baptist Memorial Hospital in Memphis, Tennessee. And we also like to say welcome to all of our newest committee chairs and committee members. We're looking forward to a wonderful next couple of years working with you all. On that note, speaking of wonderful things we've accomplished, we like to do a little shout out to everyone and thank you because we won this past year our Chapter Excellence Award from the National SCCM. So huge thank you to everyone who's participated in all of our activities over the last couple of years. You've made this chapter exactly what it is, and we'd like to recognize everyone and thank you for that. So now down to some of the business membership. Just want to remind everyone that membership is not automatic when you sign up for a national SCCM membership. So make sure you're also signing up for a Southeast chapter. But also you don't have to be a member of the national organization to be a Southeast chapter member. Our membership is only $45 annually, and that gets you at least 4 CE credits a year. We're working on a few others as well. It's a great deal. I think for most of us, we're paying a lot more for CE credits, so I think that's a great deal. And we also have other discounted prices for certain things. I'll mention a couple of them in a few minutes. Something else we have coming up is our Barbara McLean Contributions to Critical Care Nursing Award for Excellence in Nursing. Nominations are due by May 1st, and you can refer to your emails or our website for more details, SCCMSE.org. Remember, nominees do not have to be Southeast chapter members, but in order to make a nomination, you need to be a Southeast chapter member. So be sure, if you know any fantastic bedside and critical care nurses, put a nomination in for them. We also have a Fundamental of Critical Care Support course coming up on May 9th. You can also refer to our website, SCCMSE.org, for more details about cost and registration. And that's another membership discount. So you get a discounted rate for our FCCS course that's coming up in May. Also, May is National Critical Care Awareness and Recognition Month. May 18th is when we'll be celebrating all across our ICUs throughout the Southeast region. So if you're interested in doing anything at your hospital, be sure and email us at communications@sccmse.org. We can do some things for you, get you set up with some goodies to pass out to your ICU. Also, save the date. Our next meeting is June 26th. Barbara McLean will be speaking on non-invasive hemodynamic monitoring, so be sure and look for that email coming up soon. And again, just if you need any more information about any of these events or anything else or getting involved with the Southeast chapter, you can always email us at communications@sccmse.org or visit our website, sccmse.org. And now, without further ado, I'd like to introduce our speaker for tonight. Brandon Frady holds a Master's of Science in Nursing from Emory University with a specialization in critical care and is currently completing his doctorate in nursing practice education. He's currently a critical care nurse practitioner at Northside Hospital in Atlanta, Georgia. He came to Northside after nearly 12 years of critical care nursing experience. Before joining Northside, he practiced as an acute care nurse practitioner at Emory University in the cardiovascular ICU. At Northside Hospital, in addition to clinical practice, he's developed clinical programs, including the Intensivist Response Program and the Critical Care Affiliated Professions Program. He's spoken extensively on the topic of obstetrics, OB, as I told you I'd mess that word up. So everyone, please join me in welcoming Brandon Frady.
Can you hear me? All right, there we go. We're going to pull up the slides. It's very, very difficult for me to be able to do a lecture like this across the Southeast region via GoToMeeting. I currently teach at an organization where we do web-based learning, so I'm learning to be a better web-based learning educator. One of the downfalls of that is I walk around a lot. So I want to say thank you for the invitation for the Southeast region chapter of SCCM. And one of the things we're going to cover, we have a lot of topics to cover this evening around really, I called it managing the critically ill pregnant patients or pregnancy and critical care. When you look at these patients and you think about these patients, they're very vast and wide, and it's a different patient population. And so we see a lot of these patients here. Unfortunately, we see some of these events that we hope we never have to see here in relation to some of these complex issues. So I have to go up front and say a full disclosure. I have about a 90-deck slide, so I have lots of slides to try to get through. I talk fast, so if you need to, from a GoToMeeting perspective, if I'm talking too fast, in the chat box, Ashley's going to watch the chat box for us and let us know. I can slow down. And then if you have questions, if you'll put them in the chat box, but we will reserve questions till the end, till about 7 o'clock. So Ashley's going to kind of monitor the chat box. If there are any issues with technology, just let Ashley know and we'll stop and kind of get those things sorted out. So I have to start out by making a warning, okay? When I have given this lecture across the country, one of the biggest things that I get from a feedback perspective is you didn't warn me about the content that we were getting ready to cover. So you folks around the Southeast region are critical care folks. This should not be as scary to some of you, maybe as a room full of OBGYNs, okay? When we talk about things like CPR in a pregnant patient and postpartum hemorrhage and some things like that. So I really just want to let everybody know we are going to talk about some difficult topics, but from a critical care perspective, they're essential that we talk about these topics. We have to have an understanding, we have to know, because one of the biggest things that we'll find out through the lecture is if there is a patient in a maternal cardiac arrest, more than 60% of those patients have immediate return of spontaneous circulation with delivery. So there are things that we in critical care hate. You know, in the ICU, people get the OB patient is coming. Everybody starts to get really weirded out and get very, very nervous and get very overwhelmed. But if we have a little bit of knowledge, we have a little bit of information, hopefully it'll make us a little bit more comfortable. So we're going to talk about some expected pregnancy physiologic changes. And that's just to put everybody on the same page. I'm not intending to dumb down anything or to insult anyone's intelligence, but before we have a conversation about maternal conditions or pregnancy-based conditions, we all kind of have to be on the same page and get on the same page with normal pregnancy physiology. We're going to talk about pregnancy medication categories, which is very interesting. This is very timely. I'll tell you a little bit about that. There's some significant changes that take place on June the 30th. Of 2018, actually. The final portion of the rule goes into place. We're going to talk about some common causes of cardiopulmonary arrest in the obstetrical patient, and then maybe the pregnancy physiologic impacts. The way I tried to break this down for us is I looked at the causes of maternal cardiac arrest. This data is 2014 data, but you can see here the biggest one, hemorrhage, okay, is the first two, postpartum and antepartum hemorrhage, which we will talk about this evening. We're going to talk about amniotic fluid embolism this evening, sepsis, and then eclampsia and preeclampsia. And then we're going to talk about actual maternal cardiac arrest, the actual kind of doing CPR and how do we manage the patient, both mom and a little bit to the baby. I have to say up front, I am not a labor and delivery nurse. I'm not OB. That is not my area of expertise. Critical care is my area of expertise. So we will be having a focus on things related to the critical care aspects where we might actually make an impact in these patients. You'll see this slide actually again. So let's talk really briefly about some normal pregnancy physiologic changes. During pregnancy, you have between weeks 6 and 12, your plasma volume increases by 10 to 15%, and then you have rapid expansion up to 30 to 34 weeks. The basic thing is that the pregnancy is a stress test of all body systems for the whole 9 months, and it's the body's preparation for delivery. So you're increasing plasma volume for the anticipated 500 cc EBL that you have with a vaginal delivery, or a liter EBL that you have that's estimated with a C-section. Those are base norms. So you're increasing plasma volume, as well as you're increasing plasma volume for perfusion purposes for the uterus. You have red cell volume increase, maybe to a little bit of a lesser extent. And then you can see here, the non-pregnant patient has anywhere from 65 to 70 mLs per kilo of blood volume, compared to the pregnant patient has 100 mLs per kilo. So there's quite a bit of increasing blood volume. And so if you think about that, in a non-pregnant or a normal patient, if you increase their circulating volume that extent, you have to have a compensating piece of it, because otherwise the patient would be severely volume overloaded. So during pregnancy, you have systemic vascular resistance reduction. So the way that there's compensation and maintaining cardiac output is the volume goes up, but the SVR goes down. So the patient's systemic vascular resistance goes down. So you can see here the graph that we have, and I hope everybody can see it pretty well, but you can see blood volume kind of maxes around 32 weeks and starts to fall off around 40. So the volume changes are necessary for fetal circulation, but the distribution in the amniotic fluid, and then your extracellular and intracellular. We have to remember that pregnant patients also have a low colloidal oncotic pressure, so they have a lot of edema, swollen ankles, swollen everything, when it comes to the later stages of pregnancy, or the later weeks of pregnancy. There's mild edema. The interesting thing is because of the significant vasodilation, you have very little ANP or BNP effect. So the pregnant patient's BNP should be normal because of the offset of the reduction in systemic vascular resistance. So they shouldn't appear chemistry-wise volume overloaded necessarily. And then if you're using invasive monitoring, the CVP, their CVP is relatively unchanged because of this balancing nature of the lower systemic vascular resistance. So blood viscosity comes down, the increase in intravascular volume goes up by 50% near term, and that's for preservation of that potential blood loss like we talked about. And then you have a utero-placental autotransfusion. So at the time of delivery, when the placenta is actually detached, the mother will get a 500 cc fluid bolus. So they get a 500 cc bolus of blood at that time. Okay, and sometimes in critical care, when we're getting these patients, I know in our experience postoperatively, sometimes we are trying to assess what is the volume status of a postpartum patient, and we have to also kind of remember in the back of our mind, 500 cc's doesn't sound like a whole lot of blood, but if you're worried about peripartum or postpartum cardiomyopathy and a patient having heart failure and looking like they're in shock, they may actually wind up, that 500 cc transfusion can be a lot. That amount of blood can be a lot for those patients. So heart rate goes up in the first trimester, it maxes in the third trimester, and it averages 95 beats per minute. So if everybody puts their sepsis hat on right now, you have a SIRS criteria met by normal pregnancy physiology. So we're going to talk about sepsis in pregnancy very briefly, and why it's hard to use some of the inflammatory markers to actually tell us what the traditional definition, or kind of meeting some of the traditional definitions of sepsis are. And it can vary up to a little bit more than 100. So really and truly 95 to 100 is where their heart rate kind of lands for most patients. Whoops, went too fast. Cardiac output goes up can go up by 50%. Okay, it's an increase in stroke volume. Remember that these patients have the reciprocal decrease in systemic vascular resistance. Half of the increased cardiac output can happen within the first 8 weeks. Okay, it slows in the second trimester, and then it falls in the third trimester. Just as you see here, systemic vascular resistance drops, but mean arterial blood pressure is maintained in these patients. Cardiac distribution, this is important for us to remember in the pregnant patient. There's a significant portion of placental distribution there, and we'll talk about that when we come and start talking about the maternal resuscitation part, because the placenta stills a significant percentage of the cardiac output because of blood naturally shunting there. The skin and the kidneys are also. Contractility is relatively stable. Okay, and the EF is relatively unchanged. So in the normal pregnancy patient, they should have a relatively unchanged ejection fraction as long as they have a normal baseline cardiac function. We talked about systemic vascular resistance. Both systolic and diastolic fall in early gestation and remains low, and then starts to slowly, gradually rise in the third trimester back to normal. And the last kind of hemodynamic thing we need to make sure that we take into consideration when we're talking about maternal resuscitation is supine position, or what we like to call cavoatrial compression. And basically with these patients, you have a reduction in their preload and an increase in the afterload. So basically by laying a pregnant lady flat, what you're doing is putting basically the uterus sits on the vena cava and the aorta, and blood can't get back to the heart and blood can't get out of the heart. So that's why this is one of the reasons that we always put pregnant patients left lying. We get them off, right, and have improvements. We had a patient in distress recently, and it was quite an interesting look at the fact that she would be supine and you would have fetal decline, and then we rolled her over on our left and immediately it improved. It became complicated for us because it was trying to figure out, we got to lay her flat to do what we need to, but then baby's in trouble. So kind of getting that right position in place. It can reduce cardiac output in as much up to a third. So it's a significant reduction in blood flow to the patient when they're supine. Moving on to pulmonary changes, the big thing is airway consideration in these patients. Pregnant patients have a couple of things. They have a lot of hormonal changes that cause their airways to be floppy, to be very narrow. So when you're thinking about or considering intubating, endotracheally intubating a patient, you want to make sure that you're using 7/0 tubes. That's the tube that you want to hand. That's the tube you want to ask for, because their airways are pretty small. Their airways are pretty constricted. There's a lot of redundancy there, so their airways can be difficult. And then to kind of add insult to injury, the relaxation of the lower esophageal sphincter, that these patients are at huge risk for aspiration. So it's not one of those situations where, okay, we're going to intubate this pregnant patient, we're going to lay her flat and leave her laying flat until we get all of our stuff together, because the risk of aspiration is so high because of the progesterone and the relaxation of the lower esophageal sphincter. So from a critical care perspective, we already know up front before anything happens that these patients are going to be difficult intubations. So high amount or a high degree of coordination prior to endotracheal intubation is important, and making sure that basically we like to use 7/0 tubes for the most part, because that's what you're the most successful with. Minute ventilation increases, okay, in these in pregnant patients, but their respiratory rate doesn't. So their tidal volume goes up and their minute ventilation goes up, but their respiratory rate doesn't go up. So respiratory rate is a good sepsis indicator. Okay, fever and respiratory rate, because the respiratory rate in normal pregnancy physiology is unchanged. It's not changed in patients where the tidal volume goes up. And so as the tidal volume goes up, their minute ventilation goes up, resulting in a compensated respiratory alkalosis. Their functional residual capacity goes down. They do have some mechanics, obviously, clearly with a fetus in there. It depends upon the size, depends upon the diaphragm and the pressure on the diaphragm. Sometimes mechanics can be involved with actually being able to breathe. And their oxygen consumption is increased, so they will become hypoxemic very, very quickly. And if you manage or take care of OB patients on a regular basis, they can actually become very hypoxemic very, very quickly. And we'll come back in just a second to this compensated respiratory alkalosis. So when you think about acid base, the normal PaCO2 due to the compensated respiratory alkalosis is 27. That should be 34. Sorry, first typo. We're gonna track how many typos there are. It's 34. So the important thing to remember here is, if you're caring for a patient, an obstetrical patient, a pregnant patient in the ICU who's 28 weeks, 36 weeks, pregnant just in general, they're going to have a CO2 of 27 to 34. If you get a blood gas and their PaCO2 is in normal range, that is a very ominous sign for their respiratory status. So you want to start to make sure that you're intervening on these patients. And sometimes we say, oh, it's 35 to 45, it's okay, it's not that big of a deal, when actually it should really be closer to 34. The resulting alkalosis gives you a pH of 740 to 745 due to an increased bicarb loss in the kidney, which normalizes your serum bicarb in the pregnant patient to 18 to 21. So you kind of have to have an understanding of some of these terms and some of these things, because some things that we would normally treat in a non-pregnant patient, we're going to treat very differently in a pregnant patient. All right, we're done with the anatomy and the physiology overview and the lecture, so we can kind of get into the meat of some things. I just like to make sure that everybody's on the same page. So when we talk about pharmacology and pregnancy, in 2014, actually, the FDA published this content and format labeling for human prescription drugs and biologic products. And it's basically kind of been pared down to pregnancy and lactation labeling rule. You'll see it PLLR, or you'll also hear it called the final rule. Okay, and so what basically has come out of this is the requirements are that companies have to remove the pregnancy lettering category. Okay, so as of June the 30th, 2018, the medications that were basically manufactured and labeled and produced, I think, and I have it in here. So drugs after June the 30th, 2015 were all subject to the new rule. So if you have a new drug out there and you're trying to find the pregnancy category for it, you can't find it, okay? Drugs that are from June the 30th, 2001, they will be gradually phased in, and anything prior to 2001 are not going to be subject to this rule, but they have to have the pregnancy category label removed by June the 30th, 2018. So basically as of June the 30th, 2018, A, B, C, D, and X are gone, okay? They don't want you to utilize that nomenclature anymore. They want you to kind of move forward to do something a little bit different. So in this advance, so effective in 2015, they moved. It used to be pregnancy, labor and delivery, and nursing mothers used to be the original kind of drug class categories when you talk about drugs and pregnancy. And it's moved to pregnancy, which now includes labor and delivery, lactation, which includes nursing mothers, and then there's a new category here of female and male reproductive potential. And what this is aimed at trying to do is maybe not so much for us in critical care, but the primary care physicians to start counseling related to medications and the intent to get pregnant, and not only for the females, but the males, and to start to look at everything all together. So when you take a look at the PLLR here, a little bit closer look, from a pregnancy perspective, the new ruling says you have to have relevant data to use for pregnant patients. It's the potential risk to the developing fetus, and then the subheadings: risk summary, clinical considerations, and data. And then now drug companies must report if they have a registry. If they have some type of repository or a registry on these drugs, they have to disclose that they actually have that registry. What this basically says, both from a pregnancy perspective and a lactation perspective, is it's a little bit more cumbersome and laboring for the clinician, because now we have to sit down and we have to look at more data, which will be provided to us related to medications and risks and benefits for mother, fetus, and lactating mother. And we have to have a conversation. A good one, I believe, if I recall correctly, was a lot of the antidepressants were category X for a long time. So women would get pregnant, they would be on an antidepressant, it would be this category X, they would be taken off, and then they would have many sequelae and many other issues, where now when you see these patients and you counsel them, they're continuing a lot of these drugs. Because remember, X category was, we had no data. We're not sure if it's harmful or not. And so what this new PLLR says or states is that you should really look at the risk to the fetus in combination to the risk of the mother and the fetus. So it may be more risky to actually stop the medication because it increases the risk for suicide in the patient, or it increases the risk for bipolar disorder and not being able to manage themselves appropriately. So it is going to get a little bit harder for us, because I grew up in the world of ABCDX. And it was easy just to pull up my Micromedics or my UpToDate and get the pregnancy C and feel safe or not safe. And now we're going to have to look at risk benefits and have discussions, if possible, with families. and patients about medication administration. Some of this doesn't directly impact us in critical care, but the thing that's going to be the biggie is that labeling is going away. So we're going to have to kind of reframe how we look at the information. The same thing with the lactating component is that information about the drug use and lactation, and then they're going to have to start to publish the amount of the drug that's in the breast milk, so you can make a determination whether you're going to use it for lactating. And it'll be broken down into risk summary, clinical considerations, and data for both. So really the goals of the PLLR are to balance the fetal risk exposure to the risk of the untreated illness in the mother and or the fetus. So it's really, it's starting a culture change that's been coming along since 2014, really, to say, all right, these drugs, we need to look at them, we need to look at the data, we need to look at the evidence, and we need to make the best choices for the patient. So the advantages and the disadvantages of this new PLLR, it's less arbitrary and more descriptive. So you're going to, when you pull up that pregnancy category on a drug, you're going to have more descriptive material there. And we have pharmacy, with us. And so I'm sure you're starting to see, I know I'm starting to see it when I start to look up drugs, more drugs that have been developed after 2015. It says pregnancy considerations, and then it's a lot of language in there and data and information. So it's less arbitrary on A, B, C, and D, and just some kind of, there's less decision making as far as looking, less decision making related to not having the data. So you're going to now have the data to make the decision, is a better way to put it. The registry's there. It's more interpretation, it's more comprehensive data, and sometimes the data volume can be so high, it's like, what do we do with this information? How do we analyze it? How do we synthesize it? And how do we make that decision in a rapid, fast, critical care environment? We have to decide. So that's where we have to work together as a whole team and look at what are our usual routine drugs, what is our routine management, and kind of have a safe way to kind of navigate these changes. So remember, ABCDE or ABCDX is gone in what, 2 months? So kind of get used to it. So preeclampsia and eclampsia. So preeclampsia is a blood pressure greater than 160 systolic or a diastolic greater than 110, and that should be 4 hours apart in a measurement, and that's appropriately measured. And I find sometimes that we get patients that get referred to critical care and they come over for a variety of reasons. It's the appropriate management or taking of a blood pressure. Is it the right size cuff? Is it placed right? Is there a confirmation with a manual? So there's a lot of things that go involved, and it's easy for us to say, oh, what is the blood pressure, and kind of go with it, okay? For preeclampsia, it's hypertension, impaired liver dysfunction, progressive renal insufficiency, pulmonary edema, visual disturbances or cerebral edema, and then thrombocytopenia. This kind of makes up kind of the newer definition. The big thing that's not here anymore is proteinuria, the management and the measurement of proteinuria. You don't have to have the proteinuria to make the diagnosis of preeclampsia in patients, especially severe preeclampsia when they have accelerated hypertension, because you want to make sure that you're managing the blood pressure. And then eclampsia is just the seizure that results from the preeclampsia, okay? The whole entire goal by managing preeclampsia is to not have it become eclamptic, right? We don't want the patient to have a seizure, okay? The thing you have to rule out is make sure that there's no other neurologic conditions that may be present in the pregnant patient. Before, we used to think all pregnant patients were very, very healthy. One of the biggest factors that are contributing to maternal deaths now, cardiovascular disease, heart failure, AMI. We have pregnant patients going to the cath lab, pregnant patients that are getting stents put in. So cardiovascular disease is a significant portion of the mortality and morbidity makeup of pregnant patients these days. So it's not only do we look at thinking, okay, you're pregnant, so you don't have any other medical problems at all. That's actually not the case. A lot of patients we see these days have a lot of complex medical cases. So you want to make sure that they don't have any other conditions. And here again, new onset hypertension without proteinuria can still be diagnosed as a preeclampsia. The thing to remember is you want to make sure you're managing that blood pressure, because you don't want them to be hypertensive and you don't want them to have the an unintended sequela. This button is very sensitive, sorry. So approximately 1% of pregnant patients will have severe preeclampsia, and then you can see the numbers for eclampsia are much smaller, okay? Risk factors, if they've had a history for preeclampsia, some patients, the hard part is they have a history of chronic hypertension. And so how do you determine, is this chronic hypertension or is this preeclampsia superimposed on chronic hypertension, or do they just have chronic hypertension? We're going to treat it all the same. So, you know, we can treat it and then kind of figure it out on the back end. We still want to control their blood pressures. Patients with antiphospholipid, and these are relative risks out here, pre-existing diabetes, multiparate pregnancies, family history of preeclampsia. The interesting thing here to remember is, from a cardiovascular perspective, is episodes of hypertension during pregnancy increase the maternal risk for cardiovascular disease later on in life by about 7 to 8%. So there's a significant increase in maternal cardiovascular complications later on in life, hypertension, AMI, heart failure, and disease states, by having episodic hypertension during pregnancy, preeclampsia. Maternal age greater than 40. I try to avoid things like advanced maternal age. People don't like those kind of things. And then chronic hypertension. So complications, preterm delivery, okay, or issues related to delivery can be a complication of preeclampsia. Placental abruption, which can become an emergency for these patients. Strokes, acute renal failure, and then if left untreated, can be maternal and fetal death. So we want to make sure that when we have these patients and we're managing these patients, we want to be very mindful of these complications, and we want to make sure that we're treating these patients very, very aggressively, very early on. So if patients are going to be eclamptic, kind of when do they kind of fall out in eclampsia? So about half of them are going to be antepartum, so pre-delivery. So a lot of these patients will wind up with some type of obstetrical surgical intervention, a delivery of some kind, and I leave and relegate that to OB folks. Intrapartum, and then the thing for us in critical care a lot of times is maybe we get these patients postpartum who've been preeclamptic, and it's kind of a soft call, and hey, we want this patient to come to the ICU. We still need to know that there's, in the first 48 hours, the risk for them developing a seizure is pretty high. So we have to be vigilant, and we have to manage and kind of take care of them pretty aggressively. If a patient has an eclamptic seizure, they can last up to 4 minutes. Now, all of us in this room, when we have a patient seizing for 4 minutes, the thing we want to do is what? Stick an airway in, right? We want to fix someone's airway. The treatment for these patients is actually managing their blood pressure and not losing the focus of managing their blood pressure. So we will manage the seizure. A lot of times we can actually manage the seizure with antihypertensives before you even manage the seizure with a bunch of Ativan. What usually happens is they get a bunch of Ativan and then they get some antihypertensive, and then eventually you've got an airway issue because you've got someone profoundly sedated. So the big thing with an eclamptic seizure is to make sure to know that they can last, that you want to treat their blood pressure aggressively and quickly, and know that from the OB perspective or the labor and delivery nurse perspective, these patients are going to have late decelerations. The fetus is going to have compromise during the seizure because of the increase of oxygen requirement and a lot of other things that go on. So it's concerning, but don't let that be your focus of the alarm of that there's fetal distress, because you need to treat the blood pressure to get rid of the seizure. Because if you don't treat the blood pressure, you're never going to get rid of the seizure, okay? Unless you paralyze the patient, and that's not really a good thing. So how do we treat eclampsia and really preeclampsia for that matter? Magnesium sulfate depends upon where you went to school and kind of what your pharmacy and kind of your teamwork that you have. You can do a 4-gram IV infusion. You can do a larger IM infusion. You can do some smaller infusions. But the magnesium sulfate, it is neuroprotective for baby, neuroprotective for mother, and does cause some smooth muscle vasodilation from the vascular perspective of the mother. And then antihypertensives, labetalol and hydralazine are the 2 primary ones that we use. And I presented to you guys in here 2 regimens, the labetalol regimen from ACOG and the hydralazine recommendations from ACOG as far as how to manage hypertension, and we'll go through that. Monitor the airway. Resolution of the hypertension gives you no more seizures, okay? So don't be sticking things in people's mouths or doing anything like that. Let's try to resolve the blood pressure before we have to intubate. You're obviously going to need to provide supplemental oxygen if you need to provide some positive pressure assistance, but usually the seizures resolve themselves pretty quickly when you control the blood pressure. So management, we're going to treat the blood pressure and we'll talk about the specifics. Magnesium, some literature says 24 hours, some says 48 hours, some says if you need to reapply it, you can reapply it if they have a postpartum component. The things we have to remember with MAG is monitoring for MAG toxicity. So you have to do deep tendon reflexes. MAG levels really aren't useful. We will get them daily is typically what we do here, but we don't titrate based upon MAG levels. We will put them on at a standard dose, and then we'll monitor for deep tendon reflexes. We'll monitor for the neurotoxicity perspective, and then if we need to stop it, we'll stop it. And if we need to rescue, the rescue for magnesium is calcium. An interesting patient we had, it's been a while, but we've had a patient that had preeclamptic patient that was, I don't know, 28 or so weeks pregnant, and she had stroke-like symptoms. So she got brought to the ICU after having a CT scan for stroke-like symptoms. She was on a MAG drip, and her MAG level was really high, and we gave her calcium, and her stroke-like symptoms went away. So it's really more a consideration of MAG toxicity as opposed to stroke-like symptoms. So we in critical care, we got to keep our radar up, because some people think, oh, this patient has, you know, a neurologic deviation, then they're going to be treated like a stroke. But we can't take off the table, are they preeclamptic? Are they an undiagnosed preeclamptic? What do we need to do for them? So I did provide in the presentation here the Labetalol regimen and the hydralazine regimen, and it'll be published and posted for you to look at. The big thing I want to say about here is for Labetalol, you give the drug and you check the blood pressure in 10 minutes. I think sometimes in critical care, we give the drug and we want to check the pressure in 1 minute, and we want something to change. So we have to remember our pharmacodynamics of drugs in order to be able to manage these patients appropriately. So be patient. It's even longer with hydralazine. It's 20 minutes, because if you don't allow the drug to get to a half-life, then the patient has gotten 20 and 20 and 20 and 20 in 15 minutes, and then it becomes cumulative and you have an issue. So the thing I want you to take away from this is make sure that you're administering these drugs appropriately. And then if all else fails, a lot of times we'll use a nicardipine drip. That's what we use here. Use some type of IV infused calcium channel blocker. Postpartum hemorrhage, it is the leading cause of maternal mortality, okay? So you can see here some literature reports greater than 500 bleeding for a vaginal delivery or greater than 1 liter for cesarean delivery. There's a lot of controversy. I actually like the third definition, a 10% decrease in the hematocrit or the need for transfusion. Okay, because a lot of times if you think about postpartum hemorrhage, and if anybody's worked in an OR or anybody's been in a situation, determining estimated blood loss is difficult. Now you can be educated and you can be trained on how to tackle estimated blood loss, but it's still a very subjective sport, because we can look right here, we would all have a different quantity for how much blood this is, right? It's a lot. It's a whole lot. But how do we quantify what's on the floor here? It's very difficult to quantify that. So if we back up and we use a lab value, an objective lab value, or the need to transfuse somebody, it might give us a better chance at kind of managing these patients. Because postpartum hemorrhage patients, the big issue is, yes, they're hypovolemic, they go into hypovolemic shock, but then they also go into DIC and they become severely coagulopathic. So they require a lot of blood products and a lot of transfusions. The most common cause for postpartum hemorrhage is uterine atony. Massage, 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 trying to get the fundus to firm up. Okay, we've done things like 2 or 3 bags of saline on the abdomen to put pressure on the fundus, just because as the pressure is there, the tightness is there and the bleeding is reduced. So you managing the uterine atony. If it's not manageable with massage and other medications, it may become a surgical intervention, and we have to rely on our OB team to know what that looks like. It could be genital tract bleeding, retained placenta. So retained placenta is just kind of like a hole. It's kind of like a hole in the dam. It's going to keep going. So some patients may have to go back and have portions of the retained placenta removed. Uterine rupture, placenta accreta or percreta, so where the actual placenta goes through the uterine wall, and it can go through the uterine wall partially, or it can actually fully go through the uterine wall and attach itself to major vessels and major organs. Something that we don't usually see because most of those patients are referred to centers. We see them here in Atlanta because a lot of times we will get the patients referred here to be managed. And then the other thing is coagulopathy, which worsens the bleeding. So patient support from a critical care perspective, this is when we go into management of hemorrhagic shock. You know, bread and butter here for all of us, right? Big lines, big IVs, massive transfusion, you know, monitoring for acid-base balance, treating coagulopathies. Massive transfusion, there's a lot more literature coming out about massive transfusion. It still kind of relies and relays in the trauma world. But don't be fooled when you hear a 1-to-1-to-1. That's not actually 1 red blood cell to 1 FFP to 1 platelet. It's actually 4 red cells, 4 FFP, 2 platelets. Everybody has a little bit different cocktail when it comes to blood massive transfusions. Some are 4, 2, and 1. I've seen some of them actually include factor 7. You give 4 red cells, 4 FFP, 2 platelets, a cryo. You repeat that minus the cryo, and if they're still bleeding, then they get factor 7. So there's a lot of different variety out there for massive transfusion, but just know to try to keep up with it. Make sure you have appropriate vascular access for this, something to be able to do massive transfusion. And then you have to start to consider the critical care things, which we know, and things like trolley and taco and all the different things for massive transfusions that will become issues for us later. You can try oxytocin, methergin, I'm not even going to try to say that, or misoprostol. You can try these medications, but if they're massively hemorrhaging, you may either need OB to do a mechanical balloon or a packing, okay, or they need a surgical intervention. And the surgical intervention is going to be based upon the quantity of bleeding and where the suspected bleeding is coming from. Something else that you can try is interventional radiology for things like uterine artery embolizations, things like that. To kind of manage these patients. But from a critical care perspective, postpartum hemorrhages is we're managing the shock and the blood product administration. Amniotic fluid embolism is really focused on the new terminology that we kind of are hearing is anaphylactoid of pregnancy. Because when you look at this, what you actually is the proposed process, it's hypoxia, hypotension, and coagulopathy that lead to this amniotic fluid embolism. And I think I have a better slide here. So anaphylaxis triggers endogenous mediators to be released. Sepsis triggers endogenous mediators to be released, giving the clinical manifestations of a septic patient or anaphylactic shock patient. But what's proposed in the literature and what's out there to talk about amniotic fluid embolism is it is the material that's actually in the amniotic fluid. It's not the amniotic fluid itself. It's the meconium, it's the nail, it's the hair, it's the foreign objects that are in there that get pulled into maternal circulation that create this endogenous mediator release. So it's actually a little bit, we've always kind of thought of it as an embolic phenomenon as opposed to an anaphylactic phenomenon. And so these patients actually do better if they're treated from an anaphylactic phenomenon perspective, more so than an embolic perspective. And the goals of treatment are to treat hypotension, hypoxia, and coagulopathy. The interesting thing is in phase 1, they get vasodilatory, they get pulmonary vasospasm, profound hypoxia, and then it'll resolve in 15 to 30 minutes. I've actually seen this happen where we're in the L&D ORs and they're doing a C-section and they're worried about an amniotic fluid embolism because the patient precipitously hypotensive and you can't ventilate the patient. You can't bag the patient, you can't ventilate the patient, and within 10 to 15 minutes, that pulmonary component totally resolves itself and they develop a massive coagulopathy and a massive DIC, okay? So what you wanna make sure is that you kind of ride this out, okay? Ride out with it, it'll improve itself from a pulmonary perspective, and then you're left with pulmonary edema, the ARDS, and the coagulopathy, which are the other 3 components that become pretty difficult to manage. We could do a whole 2 or 3 hours on amniotic fluid embolism. Whoops. Differentials you have to worry about with amniotic fluid embolism, AMI, anaphylactic shock, anesthesia, iatrogenic events, aspiration. on inductions, placenta abruption, and then septic shock. All very similar endogenous pathways for inflammatory response. Supportive care and hemodynamic stabilization. There's no magic pill, there's no magic bullet. You just have to support these patients. Sepsis, really quickly, we are all very, very attuned to sepsis. I want to point out a couple of things. I'm going to move just a little bit quickly through the sepsis piece because you all know how to manage sepsis very, very well. Septic shock is kind of rare in pregnancy. A lot of times these patients are healthy. The interesting thing is that I know sometimes from our ICU, we figure every pregnant patient is septic when they come in because it just seems like that's what happens when they come in. And there's a low number. I mean, less than 1% are there. So traditional definitions don't work for the septic patient for the very reason when you look at SIRS and you're trying to make the diagnosis, and you're trying to utilize SIRS. And I know with the third definition of sepsis, we're kind of moving away from some of this, but it's still kind of out there. When you overlay pregnancy physiology, normal maternal pregnancy meets 1 to 2 of these deviations every time. There was a webcam issue, I heard. So somebody let us know if they can't see us, but we'll kind of keep going. So normal pregnancy physiology, heart rate up, CO2 is going to be off, temperature is going to be off, white cells are going to be off, and respiratory rate. I like to use respiratory rate. Most common in pregnant patients, fever with or without chills, hypothermia, and then tachycardia, which we really can't use. The number changes to 110, so you just shift that from 90 to 110, and then tachypnea above 24. Do we need to pause for a second?
I can still hear you. The webcam. I think it's just the like.
Oh, here, you know what? Let me see. Okay, hopefully you can see now. It's the ghost. So what we were saying is that the normal physiologic changes in pregnancy we talked about earlier impact being able to diagnose the sepsis patient. Oh no, this is not going to work. The computer must be frozen too.
Did we click back onto the? Yeah.
Okay. So severe sepsis and septic shock. I know a lot of times during flu season, we see a lot of flu patients, pregnant flu patients in our organization. Acute pyelo, retained products of conception, okay, choreo and pneumonia. And then in the presentation, I just provided kind of the most common staph, and then some of the most common kind of viral, so influenza associated with severe sepsis or septic shock in pregnancy. Remember, don't forget, not only do you have the obstetrical components, but remember you may have a non-obstetrical intra-abdominal source, okay? So don't just think that it's the pelvis is the problem with these patients. You can actually have an intra-abdominal process going on as well. Maternal and perinatal complications, ICU admissions, pulmonary edema, ARDS, these are all very similar to any other septic patient. The portion from a perinatal perspective increases the risk for preterm delivery, the development of neonatal sepsis and poor neonatal outcomes, perinatal hypoxia and acidosis, and then fetal or neonatal death. So either pre-delivery or post-delivery. So sepsis is pretty important in the pregnant patient, and we need to be very aggressive like we have with all these other things. Poor prognostic indicators, a delay in diagnosis. I think that goes with anything really, but from an obstetrical perspective, delay in diagnosis, failure to be aggressive with these patients. Remember, pregnant patients have a low colloidal oncotic pressure. They take lots of volume. They take more volume than you would necessarily think that they may take. So anticipate that they get volume. And I know there's a lot of controversy out there in the literature now about what volume and how much volume and those kind of things, but sometimes they may need more volume. If they're not responsive to the volume, and then depressed cardiac output, and then lactates. And these things are all very similar to any other septic patient. Indications for delivery, just so that we can anticipate from a critical care perspective kind of what the trajectory is for the patient. But intrauterine infections, the development of DIC, multi-organ failure, hemodynamic compromise, okay? Maybe it's due to uterine size or the uterine collapse, obviously cardiopulmonary arrest, and then fetal demise, and then a gestational age associated with a low neonatal or mortality and morbidity. Sometimes this one here becomes a law kind of thing as when what is the age of viability. So in your state, you have to know the laws around age of viability, because what I find is that when you're in these emergency situations, critical care is at the bedside, maternal fetal medicine's at the bedside, OB is at the bedside, and somebody has to help guide the ship or guide the team and like move. We got to deliver, we got to go. And so sometimes somebody has to actually make that statement. And last but not least, we'll talk about cardiopulmonary resuscitation. These few slides just let you know that it's the difference between 87 and 2009. You can see here 7.2 deaths per 100,000 live births, and it's up to 17. So it's an increasing situation. The frequency is on the rise, and the discharges, or the survival of discharge, is relatively flat. So if you work in a center where you have baby deliveries and you have maternal and fetal services and practices, the odds that you're going to see this are increasing. Okay, and it is sure by volume, by numbers. A lot of times centers that see more deliveries are going to have more issues and have more complications, but that's not always the case. Okay, you can do very few deliveries and you can have that one delivery where you have to do the resuscitative hysterotomy or the emergency C-section. So just because you don't do them very often doesn't mean that you're not going to get involved with doing them. Here are the maternal conditions: ischemic heart disease, coronary heart disease, and then you can see valvular disease and hypertension. So cardiovascular makes up a good chunk. 14.9% of maternal medical conditions associated with a maternal or resuscitation are cardiac driven. Okay, so we got to start thinking heart on some of these patients because of their increased risk. Here's the slide again about the most common causes of maternal cardiac arrest, all the way down to aortic dissection and rupture and some other random, very, very small things. You can risk stratify the obstetrical patient, just like there's a lot of early warning scoring systems out there in relation to the news and the views, and there's a lot of different metrics that can actually try to identify someone who's declining early, and there's actually 2 or 3 of them out there. This is the one from Circulation for the care of the cardiac arrest pregnant patient. And so it puts some parameters together and you score the patients. There are a lot of issues with these scorings: who does it, who looks at it, who responds, but they're definitely out there. So back to those pregnancy physiology things, remember that there's increased cardiac output, there's increased blood volume, there's decreased systemic vascular resistance. Airways are going to be an issue for these patients. Okay, and that the fact that they're enlarging uterus places cavoatrial compression. Cardiac output to the uterus, you can see in the pregnant patient 30%, and cardiac output, the percent of cardiac output with chest compressions, 30%, okay, cardiac output in non-pregnant 10%. So already the pregnant patient, when you're doing CPR on the pregnant patient, that you already have a reduced, because the uterus is kind of stealing some of that blood, but you have a significantly reduced cardiac output a lot of times because people don't pay attention to the cavoatrial compression. So really paying attention to that cavoatrial compression and really knowing that hands-off time. We push a lot of hands-off time, minimizing hands-off time. It's really, really important in the pregnant patients. A chain of survival is really, really important. And as you see in this chain of survival, it's no different than any other chain of survival. Because of what I want to impress upon everyone is that the pregnant patient who's coding is like any other patient, only there's just one extra little patient that we have to kind of deal with. But the management of these patients according to the ACLS guidelines, and I'm not going to review the ACLS guidelines, exactly the same, okay? I did point out, and I want to bring out a couple of things specifically to maternal resuscitations. Clearly, this is your ABCs here: unresponsive, not breathing. uterus at or above the umbilicus. This whole thing, we can talk about 22 weeks, we can talk about 25 weeks, we can talk about how do you manage these patients. And if you can see a baby bump, then they can be considered for concern for cavoatrial compression. So you would manage that patient if they have a uterus above the umbilicus. So you're going to activate the emergency response team, your code team, whatever it is. But in the maternal resuscitation, you have a OB, labor and delivery, and a neonatal code team. Okay, so you have to have those components. Most critical care people shy away from doing emergency hysterotomies at the bedside, so we relegate that to the OB folks who are much more expert at doing that. All of the things are the same here. Chest compression rate, same. Hand placement for pregnant patients, it used to be if you had ACLS for a while, you moved your hands up, you put your hands in the exact same spot. So there's no change. The depth is the same, the rate is the same. The only difference is this concept of continuous left uterine displacement, or LUD, okay? And performing LUD, which is very important, left uterine displacement. And I want to show you the pictures here. So what you do by using left uterine displacement is you're displacing the fetus off of the cavo and the atrial junction and helping to improve the preload and decrease the afterload so that your CPR is more effective. So if there is a maternal patient that is pregnant who goes into cardiac arrest, the left uterine displacement is the job of somebody. Okay, your team coordinator, whatever your process is, somebody needs to, it's kind of like CPR. Whoever's jumping on the chest to do chest compressions, somebody needs to be kind of getting to the abdomen and pushing and doing left uterine displacement. Okay, there are two ways to do left uterine displacement. You can stand on one side, you can stand on the patient's side, and you can on the right side, and you can displace the uterus to the left, or you can stand on the left side and pull. At our organization, we educate the first one is to stand on the side and push, because you have to maintain left uterine displacement through the resuscitative hysterotomy or the C-section, because you have to keep the baby off. So even though you're pushing the fetus off, they're going to do the C-section with you pushing the fetus off. It's our belief that you're less likely to lose your fingers. Someone wielding an 11-blade scalpel who's really weirded out, I don't want to be having to do a bunch of paperwork with lost fingers. Okay. So this is what we recommend. You do this maneuver until the baby's delivered. Okay, and once the baby's delivered, you can stop. Defibrillation, exactly the same. Same joules, same doses, same pad placement, everything. The only thing that might become an issue is if you have a scalp lead, doing fetal monitoring on a scalp lead, there's this rare occasion it can arc and burn, and you can have a very, very tiny little burn on the top of the baby's head, but mom and baby are alive. So it's the same dosage, same pad placement, everything. Airway management, remember what we talked about earlier, it's going to take a smaller ET tube. This is the case where you want to intubate these patients earlier. Okay, so a lot of times now our mantra is do a couple of rounds of CPR, and if you can bag valve mask, and you bag valve mask, but there's tenuous and they're unprotected airways, you want to intubate these patients sooner rather than later, and ventilate them sooner rather than later. A maternal resuscitation team. So this is, there's a lot of stuff on this slide, but really what I want you to take is that you have to have a maternal resuscitation team. It has to be optimized. Team dynamics have to be optimized in these situations, because critical care folks go to codes all the time. It's kind of like our adrenaline. It's the thing that we do, but it's extra special adrenaline and extra special kind of stress that happens, and so you have to practice these components. So if you do maternal resuscitation, I strongly recommend that you start doing mock resuscitations. You start to practice with this, you start to get comfortable with this, because it's kind of an important thing, and you have to have kind of a base team to be activated. Typically one OB nurse, OB anesthesia, and then the neonatal team, and depends upon your size and your space where you can strategically place those folks. This is just a graphic of the team. You have a maternal team, which is all of us. We do the airway, we do the breathing, we do the circulation, we do the CPR. You're going to manage the resuscitation according to ACLS like you do every other patient, okay? Our role is to, as a leader, if you're a leader of resuscitation, is to get that obstetrician there in order to be able to deliver. So some key things you want to know is, how long has this been going on? Okay, So we do CPR in 2-minute increments, right? We stop and do checks every 2 minutes. So that first 2 minutes is your first 2 minutes from a critical care perspective to say, can I reverse this cause quickly? Can I put the chest tube in and remove the tension pneumothorax and the patient's gonna be fine? The optimal thing is if you can correct the problem and correct the cardiopulmonary arrest and you can keep mom and baby together, that's ideal, okay? Most of the time that's not the case. So at the end of the 2-minute mark, when you're starting minute 3 going into minute 4, you need to be having your conversation with your OB so that starting at minute 4, you're starting the delivery. And if any of you have been in an emergency delivery like that, it's not drapes, it's nothing but an 11 blade and deliver, because anything that limits the time is going to limit or is going to increase the risk to the mother and the baby. So you want to have that OB team there available to you, and then the neonatal team to take over the baby. So good situational awareness, clinical situational awareness. Hey, this is a pregnant resuscitation. I know that, at that 4-minute mark, we need to be delivering. Some people get a little confused and say the baby's got to be delivered by 4 minutes. You have to start, or the literature the evidence states that you should be starting the delivery at 4 minutes. And if anybody's been involved in one, the majority of the ones that I've been involved in, it's between 45 seconds to 1.5 minutes for delivery. I mean, it's rapid. It's super quick. It's super, super fast. You want to have somebody who has that treatment plan, has that thought, that mind frame to say, okay, you're going to deliver, we're going to manage, we're going to do, okay? A recent resuscitation that I was involved in on the weekend, we had 20 people in the room. There were 5 neonatal people managing the neonatal team. There were 5 people managing the mother, and then there were 5 people part of delivery. You could have heard a pin drop in that room at certain points because our team leader made sure to say, I need you to keep it down. I need you to keep it quiet. And people were communicating amongst themselves. So it happens. It works. It can be done. You just have to have your team leader to really kind of coordinate that. So you want to be making that abdominal incision in 4 minutes. You want to strive to have the delivery by 5 minutes. The maternal team is going to continue to resuscitate mother after delivery. The neonatal team will deliver and manage neonatal, and the OB team will figure out what they're going to do surgically. If there's a return of spontaneous circulation, the patient may go to the OR to be closed, or they may temporarily close in the ICU and then go to the OR later. This is looking at emergency C-sections in maternal outcomes, and basically, mean in minutes here, you're looking at it's a statistical significance for maternal death, and the number is actually 67%. So for mothers, it's a return of spontaneous circulation is immediate after C-section in 67% of the time. So the goal here during the resuscitation is the delivery, is to focus on managing mom and delivering the patient. You can see here in one of the other studies, 55% resulted in sustained improvement in maternal hemodynamics. Just the delivery alone, the blood pressure got better, the hemodynamics got better, everything got better. I give it to you, it is scary. It's overwhelming, and it's scary to think that I'm not going to put sterile drapes down. I'm not going to put betadine down. I'm just going to deliver this baby and see what happens. But what the evidence tells us is that the delivery is going to help return of spontaneous circulation of the mother. Okay, 74% of these C-sections result in a viable newborn. And those are some numbers that are kind of hard to kind of pass along, to not really take seriously when you talk about delivering. This was a concept that came out, and it's been out, and it's a recommendation where you deliver where you are. And this makes people very nervous, because before, when you thought you had an emergency delivery, everybody wanted to go to the labor and delivery OR and be delivered in the OR. And what the evidence tells us, and you can see here, this was simulations. It's kind of hard to do this not in a simulation environment for study purposes, but you can see the average time was 4 minutes and 25 seconds with the spread there for the C-section in the labor and delivery room, whereas if they waited and transferred the patient to the OR, that went up to 7 minutes, almost 8 minutes. So that's an additional 4 minutes. That's additional 2 cycles of cardiopulmonary resuscitation that you have to go through before you're actually potentially delivering the fetus at that point. So The significant delay with the transfer says that you should do it in place, wherever the patient is, in the laboring room, in the emergency department, in the ICU, wherever they are. These patients don't get transported, they get delivered in place. So you have to have your team and your structure in place. They have a lot of checklists out there, tons of checklists out there for you to utilize. Sometimes a checklist can get in the way of an emergency. And some of the folks in Atlanta are going to recognize this because there's been lots and lots of work done on it. And we've done lots and lots of work on it. And it's probably, this looks a little bit different, but I like this component because it talks about a regular code team. And so we're working very diligently with our code team to be very team oriented and very quiet through the resuscitation. And so we took that construct and we overlaid the OB components to it as well. And it's an evolving process. But I like to utilize this slide to remind everybody when I do these talks is that it does take a coordinated team effort to do these resuscitations, and you have to practice, and you have to be willing to have these conversations, and you have to be willing to be scared to a certain extent. But if you have all of the right people there, one of the things that I kind of like out of it is that time resuscitation started, time left uterine displacement started, and what time did the C-section and then the delivery. Those numbers are there to trigger you to say, hey, where are we? It's time, we got to do a delivery, you know, so you can help kind of coordinate care. And then anesthesia is there. Post-resuscitation care, exactly the same. Due to time constraints and limitations, I don't have a whole lot of time to cover post-resuscitation care. There are not a lot of targeted temperature management in pregnant patients. Actually, I believe there's only 2 favorable outcomes and 1 favorable, so it's a very, very small number. But at that point, the delivery has taken place, so then you have to worry about bleeding complications with targeted temperature management and managing those patients. So most of the time, these patients are postpartum. There's a couple of review questions, and then we'll take questions from everybody if anybody has any questions. So what cardiac condition is associated with the highest risk for cardiopulmonary arrest in the maternal patient? And of these 3, the highest risk is pre-existing hypertension. Okay, knowing that that patient has some pre-existing hypertension. These patients are young patients. Maybe they've not had their blood pressure measured. You know, hypertension, silent killer. You don't know. Maybe they haven't been connected with good health care. Maybe they haven't been uninsured. There's a lot of different things that go into managing these patients, but making sure that you're monitoring for their hypertension component. Which of the following statements regarding pregnancy physiology is or are true? Cardiac output is increased. Remember, systemic vascular resistance is decreased. Blood volume is increased. So an M preload is increased. The majority of causes of maternal cardiac arrest are related to the pregnancy. The majority of them are. They're related to amniotic fluid embolism, postpartum hemorrhage. You know, there are smaller non-pregnant patients or non-pregnant causes, but the majority of them are. Defibrillating, what do we want to do for defibrillating the patient? It's the same. We're not doing anything any different. And then all of the following factors improve maternal outcomes except performing the C-section after transfer to the operating room. You want to do it in place. Okay. Questions. We can take questions from the chat. Ashley can help me with questions. People can unmute, I guess, Ashley, if they want to ask questions.
Yes.
I don't know how you guys usually do it.
Usually get them through text or type.
Okay.
Questions? Does anyone here have questions?
Yes.
Is there any use of like glucose or autopulse of the mechanical so that the mom can stay on left lateral?
So
I think they can hear, but maybe repeat the question
yeah.
just in case.
So the question from here in Atlanta is there any use for an automated external compressor, a Lucas device, auto pulse, or any of those kind of things? What the American Heart Association says about that resuscitation component for ACLS, the guidelines really, they don't say not to use it in any, and this is for any patient. They say to use them in highly trained, highly skilled facilities, because what generally happens is it's something that you don't use very often, and then everybody's trying to read the directions and use it, and so it becomes a barrier to the use. If you use it often, you can. It's very even difficult because you can't left tilt anymore. Before we used to just push a bunch of blankets under the pregnant lady and do CPR kind of sideways, and that doesn't actually help. So if your facility is good and trained with them, sure, you can use that device, but the guidelines, the ACLS or the American Heart Association guidelines say if you don't use it on a frequent basis, it actually worsens the whole process.
So
There's really no use unless you use it all the time. And I don't know if you've ever used one of those devices. I mean, you can get good at it, but you have to do it a lot.
cath labs are more savvy with them.
Correct, exactly.
So we have a question from Chattanooga, I believe. If a patient is in ARDS, do you still do low tidal volume ventilation or change strategies?
No, low tidal volume ventilation.
Low tidal volume ventilation is your answer.
That's easy. If the patient is pregnant, you may have to target that different CO2 level. And a lot of times when these patients are pregnant and they have high complex issues, you're not on your own, okay? Most of the time these patients have a critical care consult, they have maternal fetal medicine consult, they have OB consult, and you round frequently. So you're looking at fetal heart rate tracings, you're looking at hemodynamics, you're looking at contractions. And so you look at all of those things. And so you just have to remember that the CO2 kind of prerequisite set is a little bit different. So you're less likely to do permissive hypercapnia. You do the low tidal volume ventilation, but you don't have as wide of an angle for the permissive hypercapnia because the pH will start to cause some fetal issues. So that's why we do fetal monitoring.
Any other questions here?
I have one.
Yeah, no, it's okay.
Over Husk. Does the amount of calcium channel blockers affect that mag toxicity?
Usually we give calcium chloride or calcium gluconate as a rescue, and usually an amp usually works. A gram usually works. Depends on your organization. Some organizations don't want you giving chloride IV. They only want it in the central line. So if you're really worried about it, calcium chloride has more elemental calcium. So sometimes we'll use that piece of it, but sometimes they may need subsequent doses and you treat them based upon symptoms. So the goal is to never get there, but it happens sometimes.
That's all. We don't have anything up here, right?
Nope.
Okay.
I think that's all our questions. So thank you everyone for joining us today. If you are at a location that had vendors, including this location, be sure and stick around for the raffle. Thank you guys so much.
So let me mute this real quick. Let's see. If you guys stayed around, if you guys talked to our vendors and got your hole punch.